Hi everyone, my name's Ryan Howard and I'm a fourth-year general surgery resident at the University of Michigan. I'm really excited to share our study looking at the incidence of new persistent opioid use after inguinal hernia repair. I have no disclosures. The idea of new persistent opioid use has been getting a lot of attention in recent years, and with good reason. It basically refers to the phenomenon of an opioid-naive patient undergoing surgery, receiving a prescription for opioids that's intended to treat their initial post-op pain for maybe the first 1 or 2 days, but then going on to continue using opioids for weeks or months after surgery. Clearly, no surgeon prescribes opioids for postoperative pain with the intent that their patients will still be taking them weeks or months later, and this is likely a significant contributor to the overall opioid epidemic. Now, why is this important? Well, new persistent opioid use is common. Studies have shown it affects 5 to 20% of patients. It's also not isolated to one kind of operation. It affects 6% of patients undergoing common general surgical procedures, 10% of patients undergoing curative intent cancer surgery, and even 5% of pediatric surgery patients. This then exposes these patients to opioid-related risks and morbidity. In this study, we were specifically interested in determining the incidence of new persistent opioid use after inguinal hernia repair, which has not been previously described. Considering that roughly 700,000 inguinal hernia repairs are performed annually in the United States, any incidence of prolonged opioid use could have profound implications. To answer the question, we did a retrospective cohort study of opioid-naive adult patients who underwent inguinal hernia repair between 2008 and 2016 using an administrative health claims database of both commercial and Medicare patients. Our outcome of interest was new persistent opioid use after surgery, and we captured a number of patient-level and clinical factors to determine whether any of these factors increase the risk of developing new persistent use. A patient was identified as a new persistent opioid user if they fulfilled 3 criteria. First, they filled a perioperative opioid prescription from preoperative day 30 to postoperative day 4. Second, they filled an additional opioid prescription between postoperative days 5 to 90. And third, they filled yet another opioid prescription between postoperative days 91 to 180. In essence, this would identify a patient who was not using opioids before surgery, but then proceeds to fill opioid prescriptions continuously for at least 3 months after surgery. Using this methodology, we identified just under 60,000 patients who underwent inguinal hernia repair during the study period. The vast majority of the patients were male, mean age was 58 years old, and 2/3 of patients underwent open repair, whereas a third underwent laparoscopic repair. We found that 1.5% of patients undergoing inguinal hernia repair developed new persistent opioid use. To put this in context, considering the 700,000 inguinal hernia repairs performed annually in the United States, that's over 10,000 inguinal hernia patients developing prolonged opioid use every year. Our analysis identified some important risk factors for developing new persistent opioid use after surgery. Tobacco users had 1.5 times higher odds. Patients with pain and mental health disorders had roughly 1.4 times higher odds. And patients who experienced postoperative complications had 1.7 times higher odds of becoming new persistent opioid users after surgery. There were 2 additional important risk factors. First, if a patient's initial prescription was relatively large, they were 1.4 times more likely to develop new persistent use. And second, if the patient filled an opioid prescription in the 30 days prior to surgery, they were over 4 times more likely to develop new persistent use. Now, this is clearly a critical element, so it's important to think about these prescriptions and who is writing them. We looked at where these preoperative prescriptions came from, and unsurprisingly, surgeons prescribed the majority of these prescriptions. Similarly, primary care physicians, who are often the first provider a patient sees for hernia symptoms, prescribe 16% of these prescriptions. 8% were provided by emergency medicine physicians, less than 1% were provided by rehab and pain physicians, 16% were provided by other unspecified specialties, and 8.5% of the prescribers were unknown or missing. I think this practice is really important to highlight. Anecdotally, we know that surgeons or their clinics sometimes provide convenience prescriptions ahead of time, with the goal of helping a patient make sure that their pain meds are filled and ready in advance of their operation, and that they don't have to stop by a drugstore or hospital pharmacy after they've just had surgery. But I think these data really put that practice in a new light. In conclusion, this study found that patients undergoing inguinal hernia repair can become new persistent opioid users, consistent with studies of many other surgical procedures. Importantly, filling a prescription in the 30 days before surgery quadruples the risk of new persistent opioid use after surgery. Therefore, we think that providers and especially surgeons should abandon this practice, as it may place patients at increased risk of developing this unintended negative outcome. Thanks so much for watching this presentation, and please don't hesitate to reach out if you have any questions or want to discuss our work further. Thank you.